thank you very much for your kind invitation, and I would like to thank Dr. Dimitropoulos for his invitation, and I'm sure that we're going to have a very exciting roundtable today with my co-chairman, Dr. Malakasis. I don't want to spend more time. I would like to invite the first speaker. The first speaker is Dr. George Metaxas. He is a consultant general and oncoplastic brain surgeon at Elenas Venizelos Hospital, and his talk is entitled Diagnostic Management in Pre-Operative Therapy for Breast Cancer, What the Radiologist Should Know. Dr. Metaxas, the floor is yours.
Thank you very much, Mr. Venizelos. I would like to thank also the Hellenic Society of Breast Radiologists and the President, Mr. Dimitropoulos, for a very kind invitation in this very interesting course. The subject of my talk is Diagnostic Management in Preoperative Therapy for Breast Cancer, What the Radiologist Should Know. Of course, I'm a breast surgeon, and you will be hearing a surgeon's perspective for the radiologist's input and knowledge, what the information we need to know from the radiologist in regards with staging, image-guided diagnosis, neoadjuvant chemotherapy, and monitoring, and preoperative localization, and most of all, breast surgery planning and axillary management. And I will make some references from the recent evidence and trends in literature. Everyone should be familiar, and the radiologists, of course, should be familiar with the major changes in the last edition of the AJCC staging system, which has introduced 3 stage groups: the well-known anatomic group, the TNM system, the clinical prognostic group, which is determined by the TNM and the ERPRN HER2 status, and the pathologic prognostic stage group, which is used for patients who undergo surgery before any other treatment. It's very important for the radiologist to have good knowledge of that, and this new term of stage migration. Just a simple example for what used to be a same anatomic stage T3N0M0 tumor. Depending on the molecular biology of the tumor, it can be now have a prognostic stage of either 1B or 3B, completely different prognosis and treatment for these 2 tumors. For prognostic staging, it is assumed that patients receive appropriate systemic treatment. Triple negative tumors are upstaged as worse prognosis, and HER2 positive tumors are downstage as we have the treatment for that. So for us surgeons, it's very important for the radiologist to accurately define the tumor size, shape, or possible multifocality or multicentricity in order to map the cancer and help us decide between mastectomy and breast conservation. Same goes for the axillary lymph nodes, accurate definition of the axillary burden to decide between either limited axillary dissection or full axillary dissection, with or without radiotherapy. Radiotherapy field, which of course depends on the axillary burden and the tumor size and grade as well. And for the tumors that are defined as T4 and above, strongly consider neoadjuvant chemotherapy. Also for clinical stage 3A and above, further radiological workup may be required. In regards with diagnosis and imaging, there are many breast imaging modalities. However, in real life, we usually see our patients with the mammogram, digital mammogram, ultrasound scan, and MRI if needed, and we can manage them forward with these simple tests. Image-guided biopsy is a safe non-surgical method of choice for diagnosis, and it has completely replaced open biopsies. Fine needle aspiration has been abandoned almost, and vacuum-assisted biopsy is now replacing a core needle biopsy with all modalities under ultrasound, mammogram, or MRI guidance. So the radiologist needs to be familiar with all these techniques. The need for localization, improvement of imaging has led to the increased rate of screen-detected lesions and therefore need for localization. Also increased rate of multifocal disease And the increased use of neoadjuvant chemotherapy has led to response and preoperative lump shrinkage, and therefore need for localization and sometimes conversion from mastectomy to breast conservation. So we need all this information and localization to reduce the extent of surgery and achieve safe margins and good aesthetics. Image-guided localization is mandatory to guide surgery of non-palpable lesions, to guide surgery of palpable lesions of unsettled or abnormal margins, and also to guide surgery in multifocal disease. The techniques and timing of localization is similar to those of biopsy. The modalities are used again as mammogram, ultrasound scan, and MRI, and the timing to surgery differs depending on the hospital, the infrastructure. It could be done the same day before surgery, or up to 30 days before surgery, which remains a subject of investigation with newer techniques. The neoadjuvant chemotherapy is recommended not only for locally advanced breast cancer, but also for stage 1 to 3 cancers to reduce tumor burden, to increase the rate of breast conservation, and to serve as, mostly to serve as an in vivo sensitivity test for newer therapies, and to facilitate the study of cancer biology. The aim of preoperative treatment is complete response, which, as we all know, is correlated with overall survival, while on the other hand, residual disease burden is correlated with recurrence and death risk. Imaging with all modalities throughout neoadjuvant chemotherapy is used to predict response, prognosis, and depict those who are non-responders, maybe determine early determine the regimen effectiveness or discontinuation, change to another type of treatment or even surgery, and reduce overall the cost of ineffective treatments. The RECIST criteria has been mentioned before for almost complete response to progression. The common practice is to follow the patient throughout neoadjuvant therapy with physical exam, MRI, which is difficult to quantify, or other modalities such as ultrasound and mammogram, usually MRI baseline, mid and end of treatment, along with a marker clip before the beginning of the treatment, baseline MRI, or before the second MRI, and accurate preoperative localization of the residual disease at the end of the treatment. Implementation of quantitative imaging is essential in driving personalized care forward, and imaging methods are needed to relate to the tumor response. When the time for surgery comes, we need to plan what to localize and remove after neoadjuvant therapy. So will it be the residual tumor, the footprint, or even no surgery when we have complete response, at least at imaging level? We know in the last couple of decades that from big studies that after neoadjuvant chemotherapy, patients who have responded can have breast conservation with less extensive surgery and similar rates of re-excision, but at present there is no evidence to completely eliminate surgery even after complete radiological response. A common localization pathway is usually put in a metallic marker clip, which is visible either on mammogram, ultrasound, or MRI scan, or all of them, at the time of the core needle biopsy or the vacuum-assisted biopsy, which will act as a target for preoperative localization, will map the area of a small lesion that may be removed with vacuum-assisted biopsy that removes lots of volume of tissue, or to map lesions that in neoadjuvant chemotherapy candidates which may disappear after therapy. Immediately after the marker clip, post-marker mammogram to confirm the correct position, to assess reduction or abscess of a lesion after biopsy, and for future comparison. And before surgery, preoperative marker localization, usually with a wire or another technique, and a couple of tips: additional marking of the skin directly over the lesion, and measurement of the depth of the lesion in the operative position, which are very helpful for us surgeons. So we always appreciate a report with image, even drawing if needed, to have a more accurate picture. This is a very good example of studies that different specialties will have to collaborate to develop new strategies during neoadjuvant chemotherapy. So I-SPY Trial 2 is actually a trial platform, neoadjuvant personalized adaptive novel agents to treat breast cancer, which tests multiple new drugs across multiple cancer subtypes. So we can introduce either patients or new treatments and provide direction on personalized strategies by learning early indicators of response. These patients had preoperative tumor analysis by MRI, tissue, and blood samples. Actually, they had that repeated in 4 different occasions. And thus, we had an evaluation of an early prediction of response by lesion size, shape, extent distribution, kinetics, T2 appearance, breast density, and morphologic pattern with these 4 MRIs, and decided during the treatment whether the treatment was effective or is effective, or whether it may have to change to another treatment. There are many, when we want to decide to plan breast surgery, there are many types of localization of the lesion of the breast. Wire localization is the most popular. Carbon marking is probably the cheapest one. Nuclear tracers or nuclear seeds have been used in the past and are used currently. Radiofrequency tags, intraoperative ultrasound, and skin tattoos, they've also been studied in various studies. No single perfect method exists. We'll have to examine the scheduling flexibility of each technique, the image modalities that need to be used, nuclear medicine, probably the complexity and invasiveness, and most of all, the cost. I will make a special reference to the magnetic sheet because it's gaining popularity and it's evolving as a technique. It's been approved since 2016. It can be deployed under ultrasound guidance as most of the other localizers. In the breast, it's a small cylindrical iron particle, and it can be implanted long-term, potentially before neoadjuvant chemotherapy. It has, on the other hand, MRI artifacts, and we have to use special non-ferromagnetic surgical instruments. And in my hospital, I cannot afford it because it's very expensive. On the left side, the largest review on MAGSEED, which has demonstrated a reliable, effective, radiation-free alternative to wire-guided localization, non-inferior. And this is going to be going to be widely accepted from the surgeons due to the decoupling from complex radiology, nuclear medicine, and surgery schedules. On the right side, a few weeks ago, preliminary results from the IBRA-NET lesion localization study, 2,500 patients almost. This demonstrated a localization rate similar to that of the wire, with similar complication rates and good safety. It's going to be published by the end of the year, I think. The hot topic in breast and axillary surgery is actually axillary nodal evaluation. We need accurate assessment of the nodal burden to plan surgery or neoadjuvant chemotherapy. This can be done by ultrasound, MRI, and ultrasound-guided biopsy. There is evidence that lymph node dissection may be avoided even in selected node-positive patients. And axillary management, of course, we know is less invasive with sentinel lymph node biopsy and targeted axillary dissection, limited surgery in the axilla. So for node-positive patients treated with neoadjuvant chemotherapy, restaging axilla with ultrasound and MRI scan and limited dissection by TAD and sentinel node is recommended to minimize the false negative rate of sentinel node biopsy. So there have been efforts, and there are ongoing efforts to develop prediction models for the axillary evaluation also by imaging features that can predict nodal burden and therefore select the proper candidates for limited axillary surgery. The radiologists and the surgeons need to work closely to maximize the role of imaging at this point. So in the old days, a patient who was clinical node positive would usually end up having an axillary lymph node dissection. Nowadays, if the axillary burden on imaging is low, first of all, we need to do a needle biopsy and confirm whether the patient is node positive. And then if the burden is low, we can mark the positive lymph nodes with a marker. And then if the patient is candidate for neoadjuvant chemotherapy, they can have chemotherapy and monitoring throughout chemotherapy, usually with ultrasound and MRI scan. And then at the end of chemotherapy, again, assessment, see if the patient remains radiologically malignant, abnormal, then yes, we can consider axillary clearance. Otherwise, if the patient has become clinically node negative, then it is suggested that we can localize the clipped nodes and remove them along with the Sentinel nodes if it's not the same node in theater. So if the Sentinel node is not the clip node. And there's a lot of interest in joining these two procedures, so the lymph node marking and the lymph node localization in one procedure if we have an appropriate marker and localizer at the same time. So again, from the iSpy trial, we see that most of the surgeons that registered in this trial, they are for the clinically node positive patients that undergo a neoadjuvant chemotherapy. After chemotherapy, they would consider a limited axillary dissection, so that usually sentinel lymph node biopsy. There is a small percentage that would go for axillary clearance either way, and there is another small percentage, about 15%, who would offer enrollment in a clinical trial, which is probably the best option. The presence of axillary metastasis remains the most significant prognostic factor in breast cancer. Now, this is a series of events, actually, these studies. So we know that from the Z11 trial that abnormal mammogram, ultrasound, and MRI scan is not a reliable indicator for axillary node dissection. We also know that for clinical node positive patients that have chemotherapy, neoadjuvant chemotherapy, at the end of chemotherapy, FNA of the clipped nodes is not enough because it has high false negative rate, and we do need surgical staging. Sentinel lymph node biopsy is a valid alternative to axillary clearance post-neoadjuvant chemotherapy, but may sometimes have a high false negative rate. And nowadays, by marking the positive axilla at the time of diagnosis, so that is before neoadjuvant chemotherapy, has the aim and has managed to reduce that, what we know from the evidence, the false negative rates of sentinel node biopsy. And the best method of marking or localizing or both is still under investigation. Several methods of marking and localization. It's usually clip under ultrasound guidance, ultrasound guided clip marker, several types. And for the localization after chemotherapy, it's either radioactive seeds that were the first studies, but mostly wire, which is not technically straightforward procedure, or radioactive seeds. Studies that prove the safety and efficacy of these strategies, they incorporate radiological techniques at different stages of treatment, and the initial reports with the radioactive seeds had some difficulties to implement in many centers. So we now have the the Magellan trial, which is a prospective open-label study that is focused exactly at this point. So to use a magnetic seed as a marker both and localizer, so marker at the time of diagnosis before neoadjuvant chemotherapy and localizer after neoadjuvant chemotherapy. This is about to close, and it will, I'm sure it will publish pretty soon the results. It's a small number of patients. If it proves to be equally accurate with wire or other methods, then the second procedure of localization following neoadjuvant chemotherapy will not be necessary. It will all be done before chemotherapy, where the MAG seed will act as a marker and the localizer. However, on the other hand, we have already 4 studies that do the exact same thing with tattoo, ink tattoo, which before neoadjuvant chemotherapy, the suspicious or metastatic lymph nodes are tattooed and removed with the marker being and localizer at the same time being the tattoo. This has proved in all 4 studies to be a feasible, accurate, and obviously low-cost method. And let's not forget the neoadjuvant endocrine treatment, not only chemotherapy, but neoadjuvant endocrine treatment. Again, we will have the same algorithm and the imaging input at the beginning and during the treatment, which will help us decide during the treatment whether we can continue with the same treatment or maybe, depending on the characteristic of the tumors, tend to chemotherapy. And of course, during the beginning and the end of treatment, mark and localize the lymph nodes if required. So remember this old saying about specialties that do or know everything or nothing. I would say that the radiologists nowadays do most of the work: diagnosis, staging, biopsying, localizing, and monitoring. And the surgeon usually becomes the hero by excising. So dedicated breast radiologists are the most suitable professionals to choose these optimal techniques for those things. And they should act as a core member of the multidisciplinary team to decide what the best treatment plan is. Thank you very much.
Thank you very much, Dr. Metaxas, for your excellent and very detailed talks. I have to tell you honestly that I like your last picture about the relation between radiologists and surgeons. We have to do it, unfortunately, with our friends radiologists. I cannot see any questions or any hand raised. Therefore, I will pass over the microphone to my co-chairman, Dr. Malakasis. Dr. Metaxas, again, and once more, thank you very much.
Thank you.
Good afternoon, and from me, the next speaker, it's going to be Dr. Rodriguez Arana Ana Maria. It's head of breast imaging radiology department, breast cancer group in Valdeherborn in University Hospital of Barcelona. So you're going to speak about elevation. We want to hear from you everything.
Thank you very much. Thank you very much for the invitation. I'm feel really honored to collaborate with the colleagues. So there's no easy time for anybody. So this is the way to keep contact and to keep learning and to keep sharing knowledge. So I will start with my presentation. So I need to share desktop. Okay, this is different from the new, okay. Okay, this is the one. Now can you see my presentation? I don't have any sound.
Yes, we can hear you very well.
Okay, so can you see my presentation?
We can see your slides, yes.
Okay, so let me leave it in the mode, in the presentation mode. Okay, now I think,
Thank you.
okay, let me close this. Perfect. Okay, so elevation, a new approach to breast biopsy. This is the Hospital Materno-Infantil, is the building, Vallebrón is the second biggest hospital in Spain, is the first, is the biggest hospital in the region of Catalonia, and we are a breast cancer center. That means we work as breast cancer. We work in the same space with the breast surgeons and the oncologists dedicated to breast cancer. So that means we have a lot of volume. We treated all the cases that are seen in other primary cares. So we are like the reference center for most of the second or the primary care from the all Catalonia. So we do a lot of interventional procedures, of course, and the main thing is you can see we have all the invasive diagnostic. These are numbers from 2019. I will try this on, okay. And you see we have in the same department, we do screening and we do diagnostic mammogram, and we have dedicated ultrasound, MRI, and we have a mammogram for clinic and screening program. We do vacuum-assisted biopsy, MRI guided, and we use always markers. We do vacuum-assisted biopsy and vacuum-assisted excision, and we also do percutaneous treatment. And this is doing in close cooperation with the clinical department. So we work in a one-stop clinic protocol. And you see in 2018, we diagnose and treat almost 600 cancers. So with this frame, I will show you some pictures from Barcelona during the lockdown. I think it's interesting to see the city in these difficult times. So this is the end of Las Ramblas in the center of the old town. Okay, so my talk will be sorry, this is the previous. Okay, we're going to talk about the indication of the different invasive technique. We're going to talk about the justification of use a new device, the elevation. We will talk about the procedure. And I want to share with you 8 cases. Until last week, we already did 10, but I will show you 8 because the last 2 are not conclude, so I prefer not to show you, but we have 8 cases with the pathology results. So I will show you the different indications with the cases, and finally we will have some conclusions. So we already know that fine needle aspiration is a technique very useful in a long time ago, but right now it's just an indication for drainage of palpable cysts. If we want to do a workout in complex cysts, it could be an option, but we probably prefer the core needle biopsy. We use it in the lymph node assessment, and we use it in the clinical practice for the treatment of abscess or post-surgical collections. The fine needle aspiration has a limitation. That's why it's just using in those indication is a high rate of non-diagnostic or inadequate sample. It has a high rate of underestimation. We can't do differential diagnosis between in situ or invasive carcinoma. We don't are able to have a best performance in hormonal receptor status. And it's, of course, we need experience in the radiologist and cytologist if we want to have an accurate sample. And of course, the microcalcification is not a technique for a study of microcalcification. This is the Barceloneta beach. The core needle biopsy is the next step. The indication are the diagnosis of suspicious lesion, 4, 5, and some Barrett's 3 lesions. And of course, in lymph nodes that we want to repeat the procedure because the fine needle aspiration result is not concordant. And in those cases that we do the fine needle aspiration and result and the sample is inadequate. The current needle biopsy has limitations too for the study of microcalcification and distortions. When most of the cases we do it with ultrasound guidance. Some cases we use the ultrasound if it's able to see it and the patient prefers, or we prefer to use the ultrasound guidance because of the condition of the patient. And we know we can choose different needles between 18 and 12 gauge. And finally, the vacuum-assisted biopsy, as the previous speaker says, is almost right now the first step for us in many cases. We use the vacuum-assisted biopsy when, of course, the second step after a current needle biopsy with any kind of problem, not diagnostic or inadequate sample. We use it in the cases with discordance, the radiologic and pathological discordance with a previous current needle biopsy. We use it in cases of BRS4 lesion when we have some kind of clinical approach that we have to do a very, very specific and accurate diagnosis. Of course, in the B3 lesions, I want to talk a little bit about B3 lesion after. So in borderline B3 lesions, microcalcification, as I said before, when we use the ultrasound guidance, of course in MRI guidance and stereotactic guidance. And when we have a mass or we have a complex pattern with for example, a mass pattern with microcalcification, and we want to know if there is a component of DCIS who can set that the case will be bad prognosis, and by a patient with high risk patient with familiarity history or BRCA patient, or in lesion with only MRI lesions. So the limitation of the vacuum-assisted biopsy are, of course, small breast or deep lesion, because the technique is a little bit is more difficult than the corneal biopsy. The needle is bigger, so we need to have a very, very good biopsy technique. Is a longer procedure, is more invasive, and increase the number of post-biopsy hematomas. So we need to take in mind that issue, and is more expensive. The advantage, of course, we have greater sensitivity and specificity. We have more volume of tissue, fewer false negative, and we can use the aspiration to the drainage of the post-biopsy hematoma if we have that. And in a kind of resume, we can use a vacuum-assisted biopsy, and in this case, in this slide, I can think and differentiate vacuum-assisted biopsy with the new device, the elevation, and the previous device that we have, the Anchor and Spire. So in our institution right now, we are using the vacuum-assisted biopsy, the elevation system, as a first or second line vacuum-assisted biopsy, and we are using the Anchor when we are doing excision, vacuum-assisted excision therapeutic procedures, or where, of course, when we are using a stereotactic biopsy or MRI biopsy. So elevation is just used in case of ultrasound guidance, and we use it as a first or second line vacuum-assisted biopsy. So the indications right now for this device in our institution are we use it when we need to do a vacuum-assisted biopsy, and we need to have a big amount of tissue. So we decide to use it, and we will see it in the cases, in cases that we have to give to the pathologist a significant amount of tissue, and in complex patterns like non-typical fibroadenomas or intraductal or intracystic lesions, microcalcifications, and distortions. In just one case, in axillary lymph nodes, and we'll show you later, that we can use it, and I think that is a good option because of the strength of the vacuum I think is easier. And in B3 lesions, we are using the elevation in our daily practice in the B3 lesions. So it's important to remember that our first goal is to have a good sample, and you can see here the different differences of the samples in different technique, the size and the hematoma or the bleeding around it, the samples with the core needle biopsy, the elevation vacuum assisted biopsy, or the encore vacuum assisted biopsy. And this is very important because right now we have the different devices at our breast unit, and we have to use it taking in mind, of course, the case, the patient, the lesion, the technique that we are used to guide the procedure, and of course the predicted value of the sample. That means we need to know that we have to give to the pathology more or less tissue, and that fact will make us decide the different needle or the different technique there. So you see with the core needle biopsy, we have 20 milligrams of tissue, and you see with a 14 gauge vacuum assisted device, we have the double. And look, if we use an 11 gauge vacuum assisted needle, we have 100 milligrams. So this is important to decide when you're gonna have you're gonna give the sample, because it's important to know the positive predictive value of your function of your procedure. This is the old town without tourists. And this is a kind of resume of the justification of use vacuum-assisted biopsy devices. This is a systematic review from 2019, and you see more than 11,000 lesions with more than 2,000 upgrades in 15 countries, and the overall underestimation rate, the general one, is 17%. So you see, this is the type of the lesion, and you see there's B3 lesions, and the different kind of lesion will be associated with different risk of underestimation. So we will have to know this data to choose the needle and the device. So remember always the papilloma with atypia, the ADH, and the lobular neoplasia. They have an increased risk of malignancy, and then the radial scar, and in the less dangerous are the flat epithelial atypia and the papilloma without atypia. Okay, and this is another reference important because this is the second international consensus conference. We use these consensus as a kind of guide to treat the B3 lesions, and the conclusion is that you have to have vacuum assisted biopsy when you are talking about B3B lesion because of the risk of underestimation. So you see, the conclusion of the consensus is to always do a vacuum assisted biopsy after a coronary biopsy. In some cases you go direct to surgical biopsy as ADH or a phyllodes tumor. And in the cases that you start with a vacuum assisted biopsy, you have to go to operating room in lobular neoplasia if you don't have the possibility of a high risk surveillance. And of course in the ADH, the other, you can do vacuum assisted excision treatment. And in Spain, we have our Spanish study about B3 lesions. We are one of the centers that include patients in the clinical trial, and is to show the importance of the use of the vacuum assisted biopsy, because all the B3 lesions have to have diagnosis with a macro biopsy sample. And of course, it's very important to remember that all of these interventional procedures needs criteria from a breast care unit. So all the specialists from the breast unit have to know the technique and understand the implication of use one device or one technique or other. And of course, the decision of is always a consideration of the breast care unit. Pathologists, oncologists, radiologists, all together has to know the technique. So the procedure is the same for vacuum-assisted biopsy with encore or with elevation. This is an old picture. This is one of my colleagues, and he did his doctorate thesis using the vacuum-assisted biopsy for the treatment of benign lesion in the primary care center. So he started in 2015 to use the technique. And I don't know, I have time. I want to show you just a few parts of this video about the device. I will forward a little bit. Okay. I don't know if you can listen the audio right now. I don't know if are you listening the audio.
We are hearing only you.
Oh, sorry about it.
Don't worry. We can see the presentation.
Yeah, we can skip it.
Okay.
Yeah. So let's. Oh, I'm sorry. I'm sorry about that. I just realized that in this minute. Okay. So
yes, don't worry. Just describe yourself.
Okay.
Maybe.
This is the device. You have the triconcave tip with the integrated coaxial cannula, and you have the bottom battery. You have the this bottom means that you have any technique problem, so you have to check. It's a check bottom. You have the light. If it means this means that you're going to have like an extra strength in the cutting of the procedure because of dense breast. It calls dense mode and is a kind of AI system. And you have the button for use the pre-fire to pre-fire the needle and do the pre and post-fire procedure. And you have also the bottom for take the sample. And you have here the sample container, and is illuminated to checking the quality of the samples. Okay, this is the Olympic swimming pool, just birds in the swimming pool. And now we start with the cases, and you will see that the cases are an example of one consideration. And these examples are taking in mind the sample size that we need, and that was why we use the elevation in these cases. So this is a patient, 72 years old patient, and she had a history of rectal cancer and lung metastases since 2011. And personal history of breast cancer in the daughter, so it's a high-risk patient. And in a follow-up CT because of the rectal cancer, we saw this nodal in the left breast. So we complete the study with a mammogram, and you can see here in the upper outer quadrant of the left breast, a non-well-defined mass, maybe a speculate mass, and by ultrasound is a suspicious mass, irregular, hypoechoic, non-well-defined, and the axilla, you can see the normal lymph node. We did the corneal, the vacuum-assisted biopsy with the 14-gauge elevation needle, and we leave a clip always. We have to leave the clip after macro biopsy, because if the lesion is enough suspicious to make you use a big needle, you need to leave the clip to be sure that you are doing a perfect approach of the lesion, and check the final diagnosis was an invasive ductal carcinoma luminal B, HER2 positive. This is the second case. This is a patient with a previous carcinoma, invasive ductal carcinoma, in the year mammogram for the follow-up appeared this microcalcification, polymorphic and suspicious and regional microcalcification nearby the area of the previous lumpectomy. So of course this is a suspicious microcalcifications. For ultrasound, there's a kind of image in the ultrasound associated. This is a kind of mass, irregular mass. That's why we can do the biopsy of the microcalcification with the core needle biopsy using the ultrasound guidance. And in this case, we use also a 14-gauge needle. We can use the sample container to make the X-ray to control the microcalcification in the samples. And this case finally was in situ ductal carcinoma, high grade and Comero component. So this patient went to a mastectomy. This is the surgical specimen, and you can see the microcalcification with the wire and the previous area of the lumpectomy. The third case is a young patient with a history of bilateral benign nodules, and you see this case a mass in the upper outer quadrant of the right breast with amorphous microcalcification associated, and by ultrasound you can see the mass, heterogeneous mass with cystic and solid mixed area, very typical from a phyllodes tumor. So in this case we decided to use elevation with 14 gauge because we want to assure a lot of samples from different parts of the tumor, because as you know, the importance of this diagnosis is to find the aggressive area of the tumor to be sure if it's to be able to differentiate benign or a malignant phyllodes tumor. So in this case, we did three samples, and we confirmed the fibroadenomatosis changes in a benign tumor phyllodes tumor. And the second indication, or the second use of the elevation in our department, is the complex radiological patterns. And this is the case 4. This is an 83 patient with a previous IDC in the left breast. with a conventional treatment, and in the follow-up we saw a change in this scar. So we decided to study the scar. It was palpable also, and we had a very complex pattern in ultrasound with cystic area, with solid area, and that's why we use the elevation, and we check the calcification on the samples, and we of course leave the clip, and the final diagnosis was a fat necrosis. So because of the amount of tissue, we are very confident about the results, and we can continue the normal follow-up. The case 5 is a 50 years old woman with a mass in the screening ultrasound. The mammogram was normal, and in the ultrasound we had a suspicious mass in the outer upper quadrant from of the left breast, and we did a fourth gauge elevation, vacuum assisted no, sorry. Yeah, that's why we did a core biopsy in the first approach, and it was an intraductal papilloma with without atypia. It was a normal papilloma. In the protocol of the B3 lesions, we always do MRI to complete the assessment of the case, and it's in the protocol of the clinical trial. So this is the MRI, and you can see here the mass, speculated and suspicious, and you can see how is the restriction in the ADC map. And the second nodal that we find in the MRI was intraductal, heterogeneous, well-defined nodal. And that's why we complete the first core needle biopsy with a second step biopsy using elevation, and we do the final diagnostic was an sclerosis adenosis in intraductal papilloma. That's mean a complex sclerosing lesion. That's the final result from the first lesion, and from the second. We confirm with we start with a elevation because we don't want, we go directly to the second step. We didn't do first core and after vacuum. We did in the same patient, in the same day that we did the excision, we did the elevation in the second lesion, and the final diagnosis was a complex fibroadenoma. Okay, that's the ultrasound image. And this is the sixth case. This is the middle-aged patient with a microcalcification in the left breast. But in the ultrasound evaluation, we can see an image correlated with the mammogram image, like an area of microcysts and microcalcifications inside that area. So as a complex pattern, we start with a vacuum-assisted biopsy, 14 gauge, and we do the biopsy and we leave the clip. And we check the samples by mammogram to be sure that the excision of the microcalcifications, and the final diagnosis was in situ carcinoma, comedo with high grade. And we complete the final assessment always in these cases in complex patterns with MRI. And you can see here in the T2, you can see the hydrophilic marker. You can see in the subtraction image the non-mass suspicious enhancement, and in the MIP reconstruction, you can see all the extension of the disease and the presence of the lymph node in the low level of the axillary area, and you can see the correlation with the CT image with the clip in the middle of the suspicious area. And the next indication or a scenario that we use the device is the axillary lymph node. As I said before, just one case. This is the 83 years old patient with IDC history is the first case that I showed you before. And this patient had a lymph node, and in the context of the rectal cancer and a previous breast cancer, we decide to have enough tissue from the lymph node to be able to make a differential diagnosis between breast and rectal cancer. And we use the 14 gauge. It was my colleague, Dr. Salazar, who did the procedure, and he said that it was very safe and he was comfortable using the vacuum-assisted device in the axillary area. And finally, the V3 lesions is the last case. Is a postmenopausal patient, and in the screening mammogram, we saw a distortion in the right breast, and we did a core needle biopsy from this area, and we have previous core needle biopsy result talking about the B3 lesion. So we decided to go directly. It was a distortion pattern with the core needle biopsy, who said is B3 lesion. So we continue with the next step in our B3 lesion protocol, that is the vacuum-assisted biopsy. And this is the ultrasound image. You can see the distortion here, and you can see the important blood flow around the middle. And remember, the peripheral area is the most suspicious in those cases. So I decide to use the elevation and have samples of the middle of the distortion and the periphery, and you know that's the correct way to do it. So I use the elevation, and I start with the middle of the lesion, and you can see the hematoma. Of course, as is elevation, I couldn't vacuum the bleeding, and this is the first sample. You can see the device located in the middle of the distortion, and you can see how I'm all the time control it, and it start to bleed. You can see the active bleeding, and of course, if I was missing the vacuum in that moment, that's why I moved the proof to check that it was everything okay. So I decide to stop the procedure, do a little bit of compression, and then start with the second sample. And you see a little hypoechoic image, the previous hematoma, and I insist in that area, and I start to do the peripheral area of the distortion. You can see how the device, once you introduce the needle and you leave the top of the needle in the place that you want to biopsy, you just press the button of biopsy, and you can see the cutting part go outside the needle. Okay. And that's the image post the procedure. I want to show you that this was the final hematoma. Normally when we use the Encore, the vacuum assisted, the other device, we do a lot of vacuum to clean all the cavity and try to avoid the hematoma. Of course, in that device is not possible. You can try to drain the hematoma because you leave the coaxial cannula inside the cavity, and you try to evacuate the hematoma manually as we normally do after a vacuum assisted excision. Okay, this is the MRI after the procedure. You can see the hematoma in the middle of the distortion, and the complex, even in MRI, is a complex pattern. And finally, the result was a ductal carcinoma in situ in the surrounding area of the sclerosis complex. So that's why we decide to do it. And finally, the correlation with the final pathological result was perfect. And yeah, finally, I show you the Rambla Catalunya is the most popular and main street in Barcelona. And you can see the new normality, people walking and using the mask. That's our picture right now. And conclusion, finally, this is very clear. The choice of biopsy technique depends on clinical indications and also on having an accurate visualization of the lesion pattern. We always have to have a consent form, and we always have to use or to relieve a clip in the post-biopsy cavity. This is my mail, and I was reporting screening, and I find this beautiful image of the heart inside the breast. So thank you very much. And this means in Catalan, nobody or never lose your smile. Yeah, never lose your smile. Thank you very much.
Thank you, Dr. Rodriguez, for your presentation. I'd just like to ask you, you don't use elevation for excision just because you can't vacuum the blood?
Basically, the indication and the accepted indication is just biopsy, not excision. That's why we,
lesion?
because of the, I think because of the vacuum system.
Yeah. Okay.
Yeah.
And what is the cost approximately in Spain for this procedure?
Yeah, is a very important question. Is the same cost for a vacuum assisted biopsy with the anchor or with the elevation? And it is between 100 and 150 euros per the needle.
Okay.
Yeah. You have the handle, you have the drive, and you just pay for the needle, and it's between, depend of the center, is between 100 and 150. Yeah.
Okay. Thank you very much.
You're welcome. Thank you for the invitation.
So we're going to pass to the next speaker. It's Dr. Stodoulidou. It's very experienced breast radiology. Okay, Dr. Stodoulidou is going to speak to us about the difficulties with the calcifications in stereotactic biopsy. Thank you.
Thank you for the invitation. Thank you for being here. I am always grateful to Dr. Dimitropoulos for his preference to my face regarding my contribution to his congresses. Today we will talk about breast difficult microcalcifications and how to biopsy them. We have all now reached the conclusion that we need pre-surgical diagnosis in order for the surgeon to decide how to manage the patient as far as the axillary surgery is concerned, or the Sentinel node procedure, or either extent of an possible invasive lobular carcinoma. What do we do once we find a patient in our mammogram? We are obliged to perform magnification views in order to be able to describe most precisely about morphological features and numerically the new microcalcifications that we are about to describe. While thoughts are coming to our minds about the biopsy, we are always need to check if we can see them with the ultrasound. And once this happens, we can biopsy them with ultrasound guidance, but we must never forget to radiograph the specimen. So let's say that we have reached the conclusion that we need a stereotactic vacuum-assisted biopsy. So we have to return to our mammograms and to control each and every view in order to decide the path that we're going to choose to reach the target. We have the mediolateral plus the lateral medial axis and the craniocaudal plus the caudal cranial path. Sometimes we also perform a rehearsal with the patient in order to be sure that once we start the procedure, we will be able to finish it. So let's say that, okay, we decide to go forward, and of course we take the necessary shots in order to be able to measure the path and the depth that we're going to need. We proceed with the local anesthesia. We do have our biopsy system. We take our specimens, we radiograph them, and we control for residual microcalcification in order to put or not a clip. And we always follow the pathology in order to be in concordance with our radiological first impression. So this is the typical and first one mammotome table. We all know that the table has this opening for the breast and is connected with a mammographic system. We use this window in order to radiograph the breast, the gun, the shots that we are making in order to be sure that we are reaching the target, radiograph the specimen, and the final clip. Now, what are the difficult microcalcifications? Difficult one is a microcalcification that is difficultly seen in the mammogram because the mammographic system of the mammotome table, sometimes it is of lower diagnostic value and discriminative ways to identify microcalcifications. So sometimes we cannot find the microcalcification we wanted to biopsy. Multi-scatter microcalcification can also be a challenge because we don't know which one to choose. We are not certain in choosing the right one to perform the biopsy. Posterior wall is a problem. Findings near to the posterior wall can be a problem. The same thing happens for findings near to the skin. And thin breast is always a problem for the mammographic, the mammotome table. This is a study who has compared the digital breast tomosynthesis guided breast biopsy with the prone stereotactic biopsy. And we can all appreciate that the technical success, the time needed is much further higher for the tomosynthetic table. And with this method, the low contrast microcalcification have stopped to. This can be easily understood because we can choose the slide of the tomosynthetic views where the choose the depth, this depth, and proceed to the biopsy and be sure that we're going to reach the target and have the excision. The posterior wall is always the challenge, and especially for the findings near to the axilla, because we don't have the ability to reach that place unless we proceed putting the arm of the patient in the opening of the table, so we gain some extra tissue regarding the axillary part. Also challenging, the microcalcification near the posterior wall, but in the inner side of the breast. And here comes the sitting position of the patient. For those who might think that the chair might not be comfortable, we do have solution about changing with the table that can also allow us to position the table, the patient in the right way, so we have access to the caudal inferior part of the breast or the medial one. So this is the vertical axis of the breast, and this is a study trying to study the use of the upright tomosynthetic biopsy of the breast. And the main problem, which used to be how and to be able to find with the first and one only shoot the target through this 5x5 window, and making all the calculation. If you remember, we used to have pen and paper in order to calculate the z-axis and to find if we can proceed with the biopsy. All this is demolished because of the tomosynthesis due to the angulated stereotactic images which have replaced the scout images. So it's easy to re-identify and target the lesion. Then the depth is immediately selected by the DBT image. So the needle is inserted, let's say, automatically, and we can only do some subtle corrections in order to reach our target. So the overall procedure time is much less. They compare the upright breast tomosynthetic guided biopsy to the prone stereotactic biopsy, and the result smashed it for the upright tomosynthetic biopsy due to the technical success much higher, the mean procedure time much less, and the exposure, the number of exposure much less too. Challenging are also the microcalcifications near to the skin, because we can easily understand that we damage the skin while cutting the tissue. By using two little hooks and actually opening a little bit the access to the breast, we avoid the skin, and yes, we reach the target. The other problem is the depth of the lesion in the breast. So we have the area not enough not to touch the paddle of the receptor, which, if it happens, the machine won't let us proceed with the biopsy. So some of us use a paddle, and other ones, they create a small ball with the gloves in order to give the illusion to the machine that we have a thicker breast. And here's the solution, meaning that we have now the ability to reach the breast through the lateral or the medial way. And we can reach difficult findings even in breasts that have thickness around the 2 centimeters. And we can also position also have an access from the inferior or the upper part. This study shows us the problems that we used to have with till now used the mammotome table. The length of the notch of the mammotome is of around 2 centimeters, and the distance from the tip of the needle is around ½ centimeter. And what the machines allow us not to hurt the paddle is only around 5 millimeters. With the lateral approach, though, this is a problem solved, since we can have biopsies in breasts that have a thickness at around 2 centimeters. And Nakamura has also performed biopsy in breasts at around thickness of 1 centimeter. We also take in consideration that there are breasts with implants, and we have to be able to use the implant displace technique. So we have to isolate, to be able to isolate the findings. We have to be able to isolate the microcalcification in order to biopsy them without harming the implant. And that is all from me. Thank you for watching, and thank you for your patience.
Okay, thank you, Dr. Stodolidou. Did you finish?
Yes, I did.
Okay. Any questions, Dr. Venzelos, for Dr. Stodolidou?
No, I think it was, as usual, an excellent talk from Dr. Stodolidou. Thank you very much.
Okay. So who's next to speak?
You can go ahead, Dr. Malakassis, to present your case.
Okay. Okay, no, this one. Okay. So, what is VAE? VAE is percutaneous, minimally invasive, targeted vacuum-assisted breast excision. We can say that VAB, we need the basis for the creation of a vacuum-assisted biopsy system was to find the ideal way to diagnose and treat non-palpable lesions in the breast tissue. The most of the lesions, they're benign, 80%. So we need something minimally invasive to diagnose them and treat them sometimes. We use when we do excision, we use a 7G needle because it's possible to remove benign lesions diameter to 2.5 to 3 centimeters. It's has a competitive price. It's a competitive price method to open surgical excision. There is no need of hospitalization, and we don't need the operation room. This is some devices that we can use for excision, and in summary, we can say that VAB is generally diagnostic method, but in case of small benign lesions, also has a therapeutic aspect. So, its value in removing fibrocystic lesions, fibroadenomas, adenomas is proven. The last years, there have also been guidelines that recommend this type of biopsy to remove B3 lesions with uncertain malignant potential, such as papillomas without atypia, radial scars, flat epithelial atypical, and classical lobular neoplasia. Also, there are some patients that they don't want to have the fibroadenoma, so we can take them out, and if it's the patient wish, or if they want to begin IVF and we are afraid that they're going to grow up or they return to malignancy. Always, if we want to take something, a lesion out, we need a core biopsy or a fine needle biopsy before. How we do it? We interview and we examine it. We do a clinical examination to the patient, and we verify the results of the images that we have. If we are not sure that from the images, we do a second ultrasound examination. We do the qualification. We don't need a patient with very anxiety, and we do it. If we do biopsy, as Dr. Rodriguez says, we go to Barrett's 3, 4, or 5 Barrett's lesions. For excision, after FNA or core, we do that only in Barrett's 2 and sometimes in 3. The patient preparations, it's not necessarily something, just the blood group and the basic coagulologies, and we perform the biopsy, the excision. How? We locate the lesion with ultrasound using sterile lubricant. We do skin wheel of lidocaine. We do 6cc deep anesthesia with epinephrine, and we elevate the lesion with anesthesia if it's near the thoracic muscle. We do the skin nick, and we elevate rear end of biopsy needle and advance the probe. We monitor the position of the needle during the advancement with ultrasound. When at lesion depth, we go horizontal and advance the aperture, the chamber under the lesion. Here we see a fibroadenoma. After we see it with the ultrasound, we do a point marking to where we're going to do the incision, and we put the device. We do the anesthesia, and we elevate the lesion with anesthesia if it's near thoracic muscle, and we do the skin incision. We advance the probe, the device, horizontal, and we open the chamber under lesion parallel to the chest wall. And then we obtaining samples till we eliminate the lesion. We take samples. We use 2 specimen collectors in excision because we need one for the lesion and one for the margins, just to be sure that we take it out, all of it. And after that, we put a micro mark. We place a micro mark. We do vacuum for the blood, and we rotate aperture and remove probe, and we begin manual compression. The compression is for 15 minutes. We put just a sterile strip in the place of incision, and we put an ice pack in the bra for 4 hours. Here, just a sterile strip in where we did the incision. And what do we expect after biopsy? Possibly mild discomfort or bruising, possibly excessive bleeding, and we must inform the patient that must contact with us. And the pathology report is available in about 48 hours. The disadvantage, limitation due to the location of tumor. Sometimes it's very difficult to approach if it's near the skin or it's up near the axilla. The relatively high cost, because it's a disposable device. We hear about 100, 150 euro in, from Spain. Okay, it's not so much there. The learning curve, possible complications is the bleeding or hematoma at biopsy site, pain, skin injury, infection, pneumothorax, and Nodal's disease. We see Nodal's disease, we see a big hematoma here and pneumothorax here. So, contraindication is skin infections, anticoagulants used by patient, we must cut them for at least 10 days. Coagulopathy, patients not cooperating if it's anxious, pregnancy and implants. As let's see one case, 41 years old woman with wishing to do IVF, has this lesion in the ultrasound, is 1.5. Shear wave elastography shows that it's a benign lesion. In the 3D approach, we can see that it's lobulated. We see here that the vascularity has no vascularity inside. The margins are very fine. The cytology report after FNB, it's that it's a fibroadenoma. Okay, sorry that it's in Greek language. And she decided to take it out. Here we see the ultrasound system, the vacuum system. We use 7G needle. Here we need gloves, anesthesia, and all this stuff. And here we see the anesthesia around and below the lesion. Here we elevate the lesion. And this is the procedure, horizontal, and we cut piece by piece the fibroadenoma till we eliminate it. If you know to use ultrasound system and you have a stable hand, it has a learning curve, but it's easy. Here is the beginning of hematoma in the area. So we vacuum the hematoma. And we put the mark inside. And after that, you can see the nurse that he pressed for 15 minutes and put ice that the patient keeps inside the bra for 4 hours. This is the procedure. It's very easy, I think. And I thank you very much.
Thank you very much, Dr. Malkas, for your presentation. There is one comment from the audience, from Dr. Iannotti. So glad to hear about VA also outside UK, and we do a lot of them in UK for B3 lesions. Just to let you know, even in Greece as well, we do for B3 lesions these vacuum-assisted biopsies, Dr. Iannotti, and I'm very glad that we agree for that. Now, do we have any other questions from the audience? I cannot see anything. I cannot see any hand raised. Therefore, I will ask the two well-experienced clinicians about their comments. Dr. Stathilopoulou, she is a breast surgeon. She's a director in surgical clinic in Metropolitan Hospital, and Dr. Lanitis as well. He is a very experienced breast surgeon, and he is the director of the second surgical department at Koryallenio Benakio Hospital in Greece. Ladies first, Dr.
Thank you.
Stathilopoulos.
Thank you, everybody. Hello. Thanks very much, Dr. Dimitropoulos and the organized committee for the honor to participate in this roundtable with all these excellent presentations. And I would like to share with you a comment about what about all these precaution in this COVID era that we are going on. And especially to Dr. Rodriguez, if they do any rapid test for COVID before they perform all these biopsies, since Barcelona is also have many victims of COVID. And to share with you that we, in breast unit in Metropolitan, we do rapid test, especially with when we do vacuum assistant biopsies. I don't know if we are protected by that, but I needed to share that with you.
Thank you very much for the comment. We don't do PCR tests. We just do the normal questionnaire in the first approach by the specialist nurse. She asks about symptoms or relatives with symptoms. So just a small questionnaire. And then we use complete protection with FP2 mask, and of course all the equipment. And we have for every patient, we have a special cleaning of the room. That's why it's very useful right now have the elevation and the anchor system, because the elevation, if we use it in a COVID suspicious or any other contagious diseases, we have to close the room for the deep disinfectation. So with the elevation is very easy. And yeah, I think I answer the question.
Yes, of course. Just a comment, because we are in a very difficult position.
Yeah.
And another one that I would like to say is that with all this excision for the biopsies from the radiologists, they are still our friends. We need them. We use we collaborate with them to put all these clips and to estimate all the lesions and before using neoadjuvant chemotherapy. And we need all this collaboration is very important to us, because we are all doing the best for the patient. Thank you.
Thank you, Dr. Stathilopoulos. Dr. Lanitis.
Hey, I would like to thank Dr. Dimitropoulos myself for giving me the opportunity to participate to this excellent webinar. I've been watching all these innovations since the first speech this morning, and I'm quite impressed how far have we reached in terms of radiology. So obviously, well, talking about the speeches of Dr. Rodriguez, Dr. Christodoulidou, and Dr. Malagasis, obviously we know that our demands we're getting more demanding, and our expectations are higher on the pre-operative diagnosis. And I'm glad to see that we have more sophisticated tools in our hands, and more experienced interventionists giving us the information and the samples that we need. What I will stand on the speech of Dr. Metaxas, what the radiologists should know in this era. We know that we're living in the era of neoadjuvant chemotherapy. The last 3 years, the whole framework have changed, because early breast cancer now it's going for a pre-operative chemotherapy. So it's not enough for a radiologist just to give us a diagnosis or take a sample. We know and we need a good collaboration, and we want them to be part of the team, because we want a good marking of the area, as Dr. Metaxa says, and everybody else. We want them to be able to identify those lesions post-neoadjuvant chemotherapy. We want them to mark the lymph nodes for us to be able to do these target axillary dissections, this future, as we can say, approach for the clinical positive axilla. And we definitely need them to be part of these MDT meetings and give us the insight about what extra tests should we use, or what extra tests should not be used in each and every other patient. So we want them to know what are the surgical plans. We want them to know that we plan to do this and that and the other thing. And we definitely need good preoperative planning and good cooperation. So a couple of notes. I don't know how much time we have. I would actually stay about the planning of surgery. This is the most important thing, in my opinion. We want a good documentation of where is the tumor, where are the lesions. We want marking in each one of those tumors, and definitely we need marking in the axilla. I don't know how many radiologists in Greece, they're taking biopsies and put markers in the axillary lymph nodes. I would like, if Dr. Malagasis has an insight about that, how many radiologists are putting clips in the lymph nodes they're taking biopsies of?
I think few,
Not
but
many.
the problem is also to put in any lymph node a marker. I think the cost is very high. Don't you agree?
Definitely, but here where it comes, and I will actually ask Dr. Venizelos about that. How about having a patient with one lymph node positive that somebody took a biopsy but didn't put a clip in? Then it's going for neoadjuvant chemotherapy, and then it comes to you to be operated. Then you cannot actually do the best for this patient. Isn't that true?
Absolutely agree.
So this is what I'm talking about. We have to work as a team to know where to put clips and where not to put clips, and to know where is malpractice these times not to put a clip. I think everybody agrees with that, and I know that there are problems, and I know that it will take some time for us to reach the optimum level of cooperation, but hopefully in the near future, and by having this kind of webinars, we will all be able to cooperate correctly.
Well,
I would like also to say that we want to put markers in every biopsy, if it's lymph node or if it's a lesion, but sometimes it's not so easy. The cost is too high. I insist on that. We must find a way in Greece for that. Okay.
I think there are a lot of questions now that have been raised after Sophocles and Petros' remarks, but I don't think that this issue can be answered in this webinar. The issue of cost is really very important, but as well, the issue of marking the right lymph node is also important for the patient. Therefore, we have to think about what we're doing, and when we're doing a procedure, we have to think about the patient. And we will try all of us. I mean, we have to try very hard to reduce the cost in Greece, and to give the right plan and the best for our patient. There are two questions.
Sorry, Dr. Malekus, I want to, can you hear me?
Yes.
Yes.
Sorry, I can't, I want to correct the price, because
okay.
yeah, I think it's important.
Yeah,
Okay, fine.
we
I
listen
mean,
a price.
150
Yeah.
euros.
Yeah,
Yes.
yeah, and I'm glad to stay for the comments, because yeah, I have the information from the BART people, and is 260
Okay.
per needle. Okay.
Okay.
That's more.
Okay.
Between 250 and 300. That's the answer from BD. Sorry
Very
about it.
disappointed.
Yeah.
Thank you for that.
Rodriguez.
Yeah,
But
the price that I give you is the price that is the reference in the list of the Social Security system. That is not the price of the needle. Is the price that the the approximately the
Okay.
cost of the procedure in the social security system, and
So
that's
you have a social security system, okay?
yes, yeah, and in that cases, that's the hospital who pays that cost, because of course it's different between the cost that is real and the cost that for the social security and the cost for the private practice.
Yeah.
Okay, thank you very much for your comments, Dr. Rodriguez.
Thank
That's
you.
very kind, and thank you very much that you have explained all the matter of cost, because it's very important for us here, because
I
we thought that
understand.
it's very cheap in Spain, cheaper than in Greece, but
Yeah,
it's not the case.
I understand it. Yeah, it's
That's very
very
kind.
difficult, the prices with all these procedures, and talking about the axilla, I understand it's expensive because I started to use it many years ago in the breast, and in the beginning you suffer every time you relieve a marker. But right now are the surgeons and the breast care unit who ask us in the axilla, because they do the tailoring axillary dissection. So we mark the first lymph node who we biopsy, or we do the final aspiration. We mark that lymph node with a hydrophilic clip, and then they do the Sentinel lymph node, the conventional technique, and they take out both our clip, our clip, and the Sentinel node. Sometimes it's the same, sometimes it's not, and they decide.
It's very important, and I will agree with you. I mean, the collaboration
Exactly.
between surgeons and radiologists, as far as the axilla is concerned, I think it's very, very mandatory.
Yeah.
Without that, I don't think that we can achieve the best for our patients. I think we're
Exactly.
running a lot of time. There are quite a few questions about lymph nodes from Dr. Hatsilira. Well, something very important. Markers are reimbursed in Cyprus. Now, we have to try to have the same here in Greece.
Yes.
I would like to thank everybody for their collaboration in this round table. I think it was an excellent table, and thank you very much again, Dr. Dimitropoulos, for his kind presentation, and Dr. Malakasis, and all the
Thank
speakers.
you. Okay, I'm going to pass the microphone to Dr. Dimitropoulos now to close the session.
Do you hear me? Yes. I thank you all. You were all excellent. I would like to thank the international and Greek speakers, the coordinators and commentators, the supporting industry companies, the secretariat, the technical team, and all the participants. I hope that you were all satisfied and more informed after this webinar course. Innovation never ends. I hope that we'll have the chance in the future to organize similar courses promoting knowledge and experience, and to have the chance in the near future after COVID-19 ends to get all together in a conference with a physical presence in Athens. We will keep in touch and you will be informed about all our future education actions. Until then, stay safe. Thank you for being here with us today. Have a nice weekend.